Thank you everyone for the invitation to speak today, especially the organisers of the meeting. Really nice to be in Boston in the autumn. I'd like to remind everybody what the experts concluded when we left the last session, which is that there's going to be no antiviral solution to a functional cure unless we're prepared to wait for decades. And on that note, I can then move into this session talking about novel therapeutic HBV vaccines. And I actually really agree with that. I think there's a subset of older patients where you see gradual S antigen loss over many, many decades. We don't understand what happens in that particular subgroup, and they spontaneously functionally cure. But this subset of patients that we're seeing at the moment, where we give these new antivirals, the CAMs, whatever it may be, the siRNAs, the ASOs, and a small subset with low S antigen at baseline undergo a functional cure, that group of patients, the point of when that happens, I think that's kind of related to an immune response of some kind, which we don't fully yet understand. And what we hope to do is to make that process an active switch with novel immunotherapeutic vaccines. Okay, so with that introduction, those are my conflicts of interest. When I was asked to talk to this, what are the immune profiles generated by novel therapeutic vaccines? I thought, well, that's a funny question, because to some extent that fundamentally depends on which antigens you put in the vaccine and which vaccine platform you use, obviously. And so those are the things that you kind of measure depending on which vaccine you've used and which antigens you put in those vaccines. And I'll come back to that in just a minute. But the other thing I want to raise in this presentation is come back to this issue, which was actually discussed a lot in the last kind of session, with the effects of immune exhaustion. And I know Georg has actually raised a contentious question of whether this actually exists, just as we left the last session, in chronic hepatitis B. But the effect of this particular phenomenon on immunotherapeutic vaccines for hepatitis B and the possible effects of HBs antigen and indeed other HBV antigens on vaccine immune responses. So let's start with the different vaccine platforms and the immune responses. And I think COVID, in fact, has really highlighted this kind of concept, is that there's a breadth of kind of platform technologies now, that go from those particular platforms where we aim to enhance a B cell and antibody immune response. And those by necessity for HBV would typically encode S antigens, although it could be that core and pol antibodies through FC-mediated approaches also have important roles. To the other end of the spectrum, where you may have peptide-only vaccines where you aim to induce a T-cell response. And somewhere in the middle, you've got mRNA, nanoparticle, and viral, vectored vaccines. For example, chimpanzee adenoviral vectored vaccines, which I've kind of worked on for many, many years. Modified vaccinia ankara vaccines and other kind of vectored vaccines, which actually can induce both a profound antibody and a kind of T-cell response. So obviously what you measure depends on which of these platforms you're kind of looking at. And then for a T-cell vaccine, what might you want to put inside that T-cell vaccine against hepatitis B? And to some extent, that depends on the capacity of the technology that you're kind of using to encode HBV antigens. Some viral vectors are kind of limited by the amount of antigen you can put in them, whereas that's not the case for mRNA, for example. But we really do not know which T-cell antigens at the moment are associated with kind of viral control. Probably core and pol, but I'm not really sure, and neither is anybody else. And then how you kind of use these in prime boost strategies is another big question. So I think that's just some kind of important basic concepts to start off with. And then let's not forget that some of these platforms are much better at generating innate immunity than others, in particular the viral vectors and mRNA. And innate immunity is very important. Interferon alpha, I hate to say the word again, it's still the drug that best gives us a functional cure for patients with hepatitis B. So a viral vaccine platform that can generate an innate immune response, in addition to T-cell and antibody response, may well have added benefits. Right, so these really are 4 principles of novel immunotherapies to restore HBV immunity, and I haven't got the time to speak to all of them. But essentially, you can aim to stimulate antiviral effector cells, for example, TLR7 and TLR8, agonists. And in fact, these were looked at, I think, 10 years ago for the first time. They're able to induce ISG responses, increase NK cells and T cell reactivity. But there's very recent papers, these are being explored again. And I think the point that was made this morning, I think by Jordan, that actually these have effects rather like interferon, because actually that's what they do. They stimulate the interferon sensitivity genes. I think that's kind of true. Not sure what the roles of those are going to be. Then you can aim to redirect non-HBV specific T cells and turn them into HBV specific T cells. And Lucy Dorrell is going to talk to us about this approach a bit later on today. You can aim to rescue exhausted T cells. I am going to come back to this point in just a minute. You can engineer, especially long-acting monoclonal antibodies, very interesting at the moment in the HIV world, where long-acting monoclonal antibodies against HIV have been recently associated with suppression, and then when you end those, you get an enhanced T cell response and long-term HIV viral control. So that's an interesting area, and I think we've got to talk on that later on today. And then the thing which I really work on is therapeutic vaccines. So those are the concepts, really, of the novel immunotherapies. So I just want to go back to things we've tried in the past and haven't worked almost by definition, because we tried them in the past and we're not doing them now, so that we don't go back to these again. Way back in 1998, there were early, actually quite promising studies came out which kind of suggested if you gave repeat HBs antigen vaccination to patients, up to 50% of these patients lost HBV, DNA. Since then, we've done proper controlled trials, and that's no longer true, for sure. But actually, still, we see papers coming out. 2018, there was this paper came out. Every 8 weeks, 48 weeks, low S antigen at baseline, significant antigen decline, no control group. How did that get published? So, and if you're the author of that paper in the audience, I'm really sorry about that. And then, safety and efficacy of Advector 5, also very, very interesting, expressing core, pollen S. I think Fabian led on this particular study. Very interesting. I really like adenoviral vectors. A small effect, as you can see here, on HBs antigen levels in this dose group. In the placebo group, again, though, you can see also this kind of suppression of S antigen levels. So control groups are really important in these immunotherapeutic studies. And you can see here this small restoration of a core response in this specific patient population. So I thought that was interesting. I don't think that's being pursued anymore. I think because adenoviral vectors have been, this is an Ad5 vector, and then chimpanzee adenoviral vectors came out, which were thought to be much more promising. And then, Globimmune had this interesting construct, yeast expressing XS and core. This was in gastroenterology quite recently, again, 2018, weak increase in T cell responses. And I guess the point I want to make here, really is that protein-based vaccines are not going to generate very good, T cell responses. And I think a T cell response is going to be really important in a functional cure vaccine platform. So let's come back to this really important concept of immune exhaustion. There's two broad approaches, I think, to overcome this. One is to try to remove HBV antigens, and the other is to inhibit checkpoints. And those are fundamentally different approaches, and we don't really know whether the first one will work yet. We don't really know if the second one will work yet. We definitely don't know if the first one will work yet. Coming back to Georg's point at the end of the last talk, where he said, okay, it's definitely true that in natural infection, our immune response is doing a pretty good job. Well, that's kind of true. But it's also true that if you take a really potent vaccine, whether that's a T cell a T-cell vaccine or a protein-based vaccine, and you give that to a healthy person, and you get a really fantastic response. You then give that same vaccine to a person with chronic hepatitis B, and you have a really attenuated response. In that regard, I would say you have immune exhaustion in hepatitis B. Let's give a different name then. Let's call it functional exhaustion. Functional exhaustion of hepatitis B.
You've a lot to talk.
But here you've got this really strong T-cell response in the healthy people. This is Janssen and Janssen DNA vaccine presented at EASL. And in the chronic HBV patients, most patients there, you can see, are non-responders. And I've observed the same thing when I've made chimpanzee adenoviral vectored vaccine and modified MVA vaccines encoding all the genotype C antigens from hepatitis B. Given these in prime boost vaccine strategies, once again, you see this really nice effect in the healthy people, given on the turquoise here, and in the HBV patients, this profound suppression of your T-cell response in the hepatitis B patients. It's there, but it's nowhere near as high as in healthy people. So you definitely have what I would call functional immune exhaustion in the context of chronic hepatitis B, which fundamentally any novel therapeutic vaccine is going to have to overcome. And I think this is really nice proof of principle data from the woodchuck model that adding anti-PD-1 or anti-PD-L1 to an antiviral with a potent vaccine can both enhance your immune response and also remove CCC from the hepatocytes of this woodchuck model. This was really exciting data. It's old now. It was published in 2014, but the principle's there that this combination could be really effective. Now I want to come back to the point which we discussed earlier today. Is it safe to do so? And I think, Jordan, you said that there isn't much evidence around the kind of dose of anti-PD-1 and kind of side effects. And I would argue that's because in the cancer trials, those dosing studies haven't been done. They haven't been de-escalated. You can't de-escalate anti-PD-1 because in the cancer world, because patients have got a life-threatening, condition in front of you. And so, we're kind of, maintained at the moment at this high starting dose. And we've got an opportunity now in hepatitis B to escalate to find out whether there is an effective dose for hepatitis B. So this is Ed Gaines' publication from 2019, where he gave a single dose of IV anti-PD-1. I'd like to say this is a third of the dose that's typically given to patients, 0.3 milligrams per kilogram in 22 chronic hepatitis B patients. It was safe. There was no immune-related adverse events. And this is the HBs antigen levels here. This is ALT, and one patient had a functional cure. And in our own work, we also now have looked at 55 patients working with Vaccitech. We've got 4 groups of patients that have received MVA vaccines here, 28 days apart, Chadox 1 prime, MVA boost, Chadox prime, MVA with anti-PD-1, Chadox prime plus anti-PD-1, MVA plus anti-PD-1 for the first time. And again, at this very low dose of 0.3 mg per kilogram, we saw no immune-related adverse events here. And this is what the immune responses look like. You can see down here to start with. So in the second group here, they've got the CHAD MVA. You definitely get some enhancement of your T-cell response in the chronic HBV infected patients. Interestingly, in the peripheral blood, in those patients got the AD-MVA with the anti-PD-1, we weren't able to, measure that quite so obviously in the peripheral blood. And I think this kind of shows a difficulty in trying to profile immune markers in the peripheral blood with other things which seem to be happening in small patient numbers like this. What we did see is in the group of patients that got anti-PD-1, 2 patients here lost S antigen completely. We had HBs antigen suppression in many of the others, but mostly in those patients, again, that had low HBs antigens at baseline to start with. Now, what happens if you aim to overcome immune exhaustion by, instead of adding anti-PD-1, you drop your S antigen levels? This is a really interesting concept. I don't know yet whether this will translate into humans, but this was some very kind of provocative data, I think, published by Ula's group, which basically showed that if you give the siRNA and then you add in after that a potent vaccine, what you get there this enhancement of your antiviral CD4 and CD8 T-cell responses, and in 12 out of 12 mice, this is the AAV mouse model, you get complete loss of S antigen. So that's hugely interesting, and this is about to be replicated through some work with arbutus, where you can see here 60 patients are going to get the siRNA, and then after that the patients will get the ChAd MVA with anti-PD-1 in one of the groups. And this is going to be presented at AASLD in an oral late breaker on Sunday at AASLD, and I have got no idea what the results are. So fingers crossed for this particular vaccine, and that there's not lots of adverse events, because I've just told you I don't think there will be. Right, so I'd like to end there. So immune profiles are not always easy to compare between different studies, and actually they're rarely the primary endpoint anyway, even in HBV vaccine immune therapy studies. And we're certainly not measuring immune responses very carefully or accurately in all the antiviral studies we've talked about today, which we should be doing a better job of, I think. There are novel, excellent vaccine platforms, but responses in chronic hepatitis B are and will be weak, even if you use the most potent vaccines, unless you also attempt to address this issue of immune T-cell exhaustion, for sure. And then regarding new antivirals, I think we are going to need additional agents to restore immunity. Not sure what that exactly is going to look like yet. Maybe anti-PD-1, maybe the siRNAs, but I don't think we yet fully understand if actually lowering the S antigen allows kind of reversal of the immune exhaustion phenomenon. And we may need to combine any of these with other kind of strategies to enhance innate immunity. And I hate to therefore end my last word with interferon, but I will. So thanks for listening.